Hello, everyone, and welcome to the Social Determinants of Health Academy. This is Sharina Higgins with the National Center for Medical Legal Partnerships. In just a moment, I will turn the presentation over to my colleagues on the panel today. But first, I have a few housekeeping things that I'd like to run through with you all. We have a large number of participants on this webinar today, so everyone is muted and will remain so throughout the duration of the session. On your sidebar on the webinar platform, you have a space entitled Questions. If you have a question, please feel free to send it in that space. All questions will come to me, and if it's technical assistance related, I'll do my best to answer the question. And if it's content related, I will hold on to that for the panelists to answer during the question and answer portion of this session. Just so everyone knows, the audio recording from today's session will be sent to all participants and available after the session concludes. Next slide. These are our goals and objectives of the Social Determinants of Health Academy. We are about halfway through the series, and we have really appreciated working and having everybody join us for these sessions. And we also appreciate all the feedback that you have given us thus far. Next slide. And this is a list of all of our national cooperative agreements that are faculty members for the Social Determinants of Health Academy. Just so everyone knows, there is a PDF version of the slides that we are going through today, and they're available in the handout section of the webinar platform. You will also be emailed a PDF of the slides after the session wraps. If you enjoy the training today and are interested in other trainings, you can check out our SDOH Academy homepage for more information. I'm going to go ahead and pop that in the chat box for you now for your reference. And next slide. Thank you. Today's topic is Pathways to Cross-Sector Partnerships. This is our fourth training in the SDOH Academy series, and we have a very lively panel today. We have speakers from the National Center for Medical Legal Partnerships, SchoolBased Health Alliance, Erie Family Health Centers, Family Care Health Centers, and Emory University. Each panelist will introduce themselves at the beginning of their content. I'm going to go ahead and pass it over to my colleague, Ellen Lawton at the National Center for Medical Legal Partnerships to get us started. Ellen, take it away.
Great. Thanks, Sharina. And hi, everybody. I'm so glad to be with you today and to be talking with you and also to be part of such a wonderful panel. So I just want to kick this off and ask you out there in webinar land, in the past 6 months, has a patient told you about a problem with housing or their child's education or their job? And what did you do with this information? That's really what we're going to be talking about today. Next slide. As I know many, if not most, or perhaps all of you know, the health centers are screening for these common social problems, and they're using tools like Prepare and Accountable Health Communities and other tools that have been developed to try to capture this information. And so in all likelihood, you have asked those questions of patients, they've given you responses, and you've been screening your patient population and trying to address some of those issues. Once you get that positive screen, you're probably trying to sort out how to address the problems and what workforce do I need to resolve the issues that patients are walking into the health center with every day. Next slide. We're going to talk with you today about medical legal partnerships. Here's a definition to get you started. An intervention where legal and healthcare professionals collaborate to help patients resolve social and environmental factors that contribute to health disparities and have a remedy in law. It's long, it's complex, it's a little bit like how lawyers think. Oops. All right. Go back to, there we are, the definition slide. And, but the bottom line is our job at the National Center and the programs that we're working with around the country are trying to integrate public interest lawyers as part of their healthcare team so they can tackle some of these complex issues that patients are presenting and that are challenging providers to provide the best care that they can. Next slide. This slide just sort of details a little bit for you how lawyers, it should say, help solve SDOH problems, because we know that there is a vast, or not vast enough perhaps, workforce in the health center that is dedicated to resolving some of these issues. There may be patient navigators or community health workers certainly physicians and nurse practitioners and case managers, all of whom are thinking in different ways about how to tackle some of these problems that are really challenging families and impeding health. And you can see the problems listed out here, from income and housing and utilities to education and employment. What we know from the MLP field is that oftentimes legal interventions, when twinned with community health worker or social worker interventions, can derive a financial benefit for patients in increased public benefits and increased access to SNAP benefits, et cetera. So there are real tangible outcomes that can be achieved when lawyers are partnering together with healthcare team members. Next slide. The model of medical legal partnership has grown over the past 20 years. It started with a handful of programs about 20 years ago, and now there are about 375 actually, our new numbers, medical legal partnerships around the country. And our biggest growth is happening in health centers, and that makes a lot of sense given the work that you're doing, the patients that you're seeing, and the mission that your organization has. And so we're pleased to work in tandem with health centers and primary care associations to try to boost access to this really important resource for patients and for providers. Next slide. I want to point you to a key resource, and my colleague Sharina is going to detail some additional resources that I think will help explain the role of medical legal partnership in tackling health disparities, in promoting health equity. And part of what this article does, it was released last month, is it's a review of the medical legal partnership field, and it highlights work that's happening both in health centers and hospitals and health systems, and it talks about mechanisms that programs can use to try to take a population health approach to implementing legal services in the healthcare setting and achieving some of the goals that I know we all share for our patients and our organizations. What we know from the research that our research team did in prepping this article is getting a better understanding of the different models of implementation that are happening out in the field and the different ways in which health centers are partnering with primary care associations, health systems, health departments, and others in order to promote this approach. Next slide. And along those lines, we know that treating the patient in front of us is crucially important, and we know medical legal partnerships seek to do that. But we also see tremendous activity in the medical legal partnership field around translating those individual patient experiences into policy gains. And you're going to hear from two medical legal partnership practitioners on our panel who are going to talk about some of those issues. And we are releasing at the National Center a Patients to Policy series, and one of those just dropped today. We can put that up in the chat box. And what you're going to learn is that because the lawyers and the healthcare team were working closely together at this federally qualified health center in Washington, D.C., they were able to actually prevent some insurance issues that were going to deeply affect their vulnerable patient population. And that's a great story to tell, and it's a great story to understand what the opportunity is for this cross-sector partnership. Now I'm going to hand it over to my colleague, Sharina.
All right, I just wanted to address, there were a couple people having a couple of audio issues. I just want to let you know that this is being recorded, and we'll be able to share the recording with you. I'm not hearing the audio issues. I'm not sure if it's just some certain audio that's happening across a couple different people's phone lines, but I just encourage you to call in via your phone line. Make sure that you're not called in on your phone and your computer, because you might get some echo there. Okay, so I'm going to go ahead and go into my content. Again, hi everyone, this is Sharina Higgins. I'm with the National Center for Medical Legal Partnership. I'm the research associate there, and I'm trained as a public health professional and a community health educator. I work very closely with the field on training and technical assistance for medical legal partnerships. Today, I'm going to give you a brief overview of some of the resources available at our organization. First up, I'm going to send a chat, you can go back to the previous slide. Thanks, Kaylin. I'm going to send in the chat box a link to our resource page on our website, so you can have that for your reference. We have a variety of resources available on our website. We have several different types of resources, such as issue briefs, research articles, patients to policy stories, and more. You can see the first patients to policy story that Ellen just mentioned in her section on the top of our research page that I just sent in the chat box. In addition to those types of resources, we also run monthly medical legal partnership office hours that you and your partners can join to have your questions answered. And you can also catch us at national conferences throughout the year. I will now give you a brief overview of a couple of our main resources. Next slide. First up, we have our health center issue brief. This is one of our most recent issue briefs, and it describes how health centers operate in medical legal partnerships in their spaces, and how state primary care associations are supporting these programs. It also discusses how they are financed, and it spotlights 4 states that are integrating financing for legal services and Medicaid payment arrangements. Our research shows that health centers represent the fastest growing sector for medical legal partnership adoption across the healthcare system. I'm going to go ahead and pop in the chat box this issue brief so that you have it for your reference as well. Next slide. And this is our MLP site survey report. This site survey was based on a national survey to health and legal organizations that were actively operating medical legal partnerships in the 2016 calendar year. We received 232 survey responses from 42 states, including Washington, D.C. The report includes key findings and trends in the medical legal partnership field. We recently issued another survey this year to update our internal database of MLPs. And as Ellen mentioned, we are currently at about 375 healthcare organizations across the country with a medical legal partnership. Next slide. And if you would like to learn more about medical legal partnerships, or if you have any additional questions, please feel free to reach out to Ellen or myself for more information. We're going to go ahead and pass it on to our next group at the School-Based Health Alliance to give you an overview of their National Cooperative Agreement. And then we're going to go into our panelist discussion. Tiara, take it away.
Thank you, Sharina. Hi, everyone. My name is Tiara Brooks, and I am assistant for our programs team at School-Based Health Alliance. I also help with many of our initiatives, including providing support on webinars and technical assistance. And I'm very happy to join everyone today. Now to let you know more about School-Based Health Alliance. We support school-based health centers through technical assistance and training. We advocate for SBHCs on the federal, state, and local levels. We demonstrate the value of SBHCs with common standards, measures, data, and research. Next slide, please. Since 2008, the Bureau of Primary Health Care has funded the School-Based Health Alliance through the National Cooperative Agreement to help school-based and community safety net providers regarding school-aged children and adolescent health, such as improving health, access, and equity. Through a diverse set of activities, the Youth Safety Net Project translates the science of population health and the social determinants of health, SDOH, approach in practical, clinical tools and competencies that get to the root cause of poor health for our nation's youth. Products including toolkits, blogs, webinar recordings, and more are available on our website, and there are a few related SDOH to highlight in particular. Next slide. One is health centers in schools, uniting for young people's success. At the heart of the school-based healthcare model, it is the partnership between schools and health centers that give or support the services offered to the students. And this extends to many forms beyond the traditional SBHC model. This online toolkit explores school and health center partnerships, such as oral health programs, implementing vaccine clinics at schools, educating teachers on key health topics, mutual goals achieved between school and health center collaborations, and tools for health centers to start or increase school connections. Next slide. The Youth Safety Net Project, also provides numerous opportunities for health centers to connect and engage directly in shared training and learning to boost health outcomes for school-age children and adolescents. So stay tuned for these offerings that you are viewing on your screen opening throughout the year. Next slide. Please join us at our 2018 National Convention in Indianapolis, Indiana. As shown on the previous screen, one of the upcoming learning collaboratives is Motivational Interviewing that will kick off as our free pre-conference to all healthcare programs on Sunday, June 24th, 2018. This interactive workshop equips you to use motivational interviewing to improve your ability to identify risk behaviors and social determinants of health, communicate effectively with teams, and motivate them toward healthy decisions. As a premier national gathering for our field, the convention is a fantastic opportunity to connect with hundreds of fellow school-based healthcare professionals and advocates from across the nation. Next slide. For more information about the Youth Safety Net Project or the School-Based Health Alliance, please contact me, Tiara Brooks, or my colleagues, Selena Moore or Andrea Shore. Thank you again for attending, and at this time, I will turn it over to Martha Glenn.
Hi, good afternoon, everyone, and thank you for having me on this webinar. My name is Martha Glenn. I'm a family nurse practitioner. I work at a federally qualified healthcare center, Erie Family Health Center in Chicago. I'm the medical director of our school-based program. At Erie, we have 7 community health centers, 5 school health centers, and 1 teen center. So we have 3 school health centers located within high schools, 2 located in elementary schools, which also serve community members, and then the freestanding teen center. Next slide, please. So in 2010, we joined a medical legal partnership with Loyola, and this is a slide just kind of showing our partnership and also some of the other partners that we work with Northwestern University Family Medicine residency program. We work with Loyola School of Medicine, School of Social Work, School of Public Health, and then we have a number of other legal agencies, the Legal Assistant Foundation of Chicago, the Chicago Lawyers Committee for Better Housing, a group called Equip for Equality, which helps us with our special ed and disability referrals. And our next slide, please. So our goal of our project, of course, is aimed at alleviating some of the disparities in the social determinants of health. In fact, the top 3 referrals in our school health program revolve around insurance, food, and housing. Next slide, please. So this is Lenise Walker and her family, and they are my patients at one of our elementary school sites. Ms. Walker brought one of her children in to our school health center for a school physical, and we found that her lead level was greatly elevated. She had just moved into a new apartment, and she was concerned that there were some issues in the quality of the housing. The city went out to her home, inspected the home, found lead paint and evidence of lead paint in the environment. And over time, we were assuming that the landlord was fixing these problems, but instead of getting better, a couple of the children's lead levels were getting worse. And she was very concerned that the landlord was not using the proper techniques to remove the lead from the environment. Her apartment was through a voucher with the Chicago Housing Authority, and she asked them 3 times to move into another apartment. And she just said, I'm not safe there. My children are not safe there. And every time she would ask, the CHA people would say, well, their lead isn't high enough for us to give you a new apartment. Your child's lead level should be over 20 micrograms. So I generated a referral to the Health Justice Project. They moved her into a new apartment, and they tested the apartment for lead hazards before she moved in. And so then she moved into a safer unit. But her story just continued not to sit well with us, with the attorneys. And, just the fact that she had to ask 3 times to move, and she kept being told that the children's lead levels weren't high enough, was just really disturbing. We wondered, how many other people were going to be in this situation. And what we uncovered was that there was a major flaw in the policy of the Chicago Housing Authority, and they had not updated their standards for what the definition of lead poisoning being 5 micrograms or more. And so one of the attorneys and I went to testify to the Chicago Housing Authority at an open hearing, and we brought up this fact, and they listened, but they didn't change their policy. So then, we were getting very frustrated, and we contacted some journalists, and we asked if they would like to, we put out a press release to see, would somebody like to write a story about our family and their case. And the Associated Press picked up the story, interviewed Ms. Walker, discussed, kind of gave a nice overview of medical legal partnerships. And then the Chicago Tribune picked up the story and put her story on the front page of the Tribune. So now we were getting phone calls from CHA saying, hey, I think we actually would like to talk with you privately about the things going on with your clients. Could we make, have a meeting to discuss what's going on? And what we determined was that really the problem was much bigger than what was going on in the Chicago Housing Authority. The problem was really in on the federal level. Next slide. So, we then actually went through and we petitioned HUD to fix their policy. We met with scientists, with community activists and groups, and we put together a petition for rulemaking. And we sent it to HUD in February of 2016 with an outline just like, well, here are the things that you need to do to fix this problem. You need to inspect the unit before you put families with vulnerable children in there. You need to, if you do find a hazard, then you need to allow them to move or, fix it in a way that does not expose them to more lead. And you need to notify your residents that there's a lead hazard in their building. And then you need to continue to evaluate those buildings on a regular basis, especially when you know that there's been lead in that building before. So next slide, please. So our article that was in the Tribune and the Associated Press did catch the eye of Senator Dick Durbin, our senator from Illinois, and he was just kind of shocked that federal policy was leaving so many families in a vulnerable state. And this picture is a roundtable that we held at Erie Family Health Center with our head of pediatrics, our CEO, Senator Durbin, Emily Benfer, who founded our Health Justice Project, and one of her student attorneys, and the parents are at the table. Lenise Walker and another client of the Health Justice Project who have children who have been affected by lead poisoning are at the table putting their input in. And I just think that this is just a wonderful, it was a wonderful opportunity for people who live in very vulnerable states, who usually don't get a voice, or their problems are not listened to. Next slide, please. So Senator Durbin introduced some legislation called the LeadSafe Housing Act of 2017. It would require pre-rental lead hazard inspections in all federally assisted housing where children who are under 6 live, and also gives families the right to relocate if they're in an unsafe environment. Next slide, please. So here's a summary of some of the bigger legislative issues that some of our cases have touched. One thing that we certainly have a lot of work around lead and lead poisoning, but we've also expanded health insurance benefits to homeless youth in Illinois and food benefits to them. We've expanded confidential mental health services to teens. We've gotten the Chicago Housing Authority to change their lead policy. We actually forced HUD to change their federal standards around lead. And we asked the Illinois Department of Public Health to start looking at their lead policy. Our work, of course, also inspired Senator Durbin to introduce federal legislation. And right now, one of the exciting things that we're working on is getting Illinois to, as a state, to adopt the CDC standards for intervention when lead levels are 5 micrograms or higher. And certainly, there have been thousands of individual clients helped by the medical legal partnership that we have. So that's a little bit about our story. I could probably talk about lead poisoning for hours, but I've just learned so much by this project, and really encourage, if you are thinking about starting a medical legal partnership, I would strongly encourage it. So I'd like to turn it over now to Jill Taylor, who is going to talk about their medical legal partnership.
Thank you, Martha. Good afternoon, everybody. I'm excited to share our information with you. My name is Jill Taylor. My background is in social work and family therapy. I joined Family Care Health Centers in 2016 to develop a community health worker program, and I worked in a community mental health center for 15 years before that. So I have a lot of experience working on social determinants of health with a number of different populations of people. And so I really appreciate, over the years, I really appreciate the role of attorneys in a partnership and working with social workers and other healthcare professionals. Our medical legal partnership is between Family Care Health Centers and Legal Services of Eastern Missouri. Next slide, please. At Family Care Health Centers, we are located in the city of St. Louis. We have 2 health centers. In the city, we serve 22,000 patients, over 22,000 patients, who live in St. Louis City, St. Louis County, and the surrounding areas. More than 50% of our patients are at 100% poverty level or below. 25% of our patients are uninsured. Approximately 50% of our patients receive Medicaid, and 15% of our patients are best served in another language. Here we have a picture of our team. A couple of the legal partners are missing from the picture, but I still want to show it because one of the attorneys is there. We have 5 community health workers, and then the community health team leader, who is myself, is in the picture, the medical legal partnership actually started in December of 2015. So that was before I was here. And the original model was that it was just a general MLP. Everyone who was a patient at family care health centers was eligible for services, spreading a wide range of legal services. There was no wrong door. Patients could walk in, call in, sign up at the front desk, or be referred by any care team member. But what we found is a lot of time and resources were used on patients who, one, we thought were patients, but actually walked through the door and signed up to see a lawyer, and we found out that they weren't even patients, or we had patients who were receiving legal services and hadn't actually been at the health center for a few years. And no one was screening social determinants of health in the original MLP model. So next slide, please. We shifted to a new model in August of 2017. There were a couple of different influences. One is family care health centers decided to hire 5 community health, myself as the leader, and then also 5 community health workers in January 2017. So we want to take a strategic approach to addressing social determinants of health through the utilization of the community health workers and their unique relationship with the communities that we serve. And then also the MLP attorneys and myself, we went to the National Medical Legal Partnership Conference in April of 2017, where there's a heavy emphasis on collecting data and specifically with target populations. So after that conference, Amanda Schneider, who is the project director of the Medical Legal Partnership, and I met, and we started conversations, which then we brought in leaders of family care health centers and legal services of Eastern Missouri, and we really wanted to consider which target population would best benefit our medical team, and also that the legal team thought they might be able to help. So we also wanted to align with HRSA's priorities, and we also wanted to take a look at, what services we were offering to our population of patients who have uncontrolled diabetes. And through all of those different factors, we ultimately decided to focus our legal efforts on our patients who have uncontrolled diabetes. Next slide, please. So we had to develop some workflow. So our community health workers are screening all patients, refer to them for social determinants of health using Prepare. And then they also respond to, whatever comes up as terms of social determinants. And Ellen reviewed, what the Prepare tool is, and I know many of you probably are familiar with it already. So the community health workers, once they are screening patients, they work in combination with myself and our legal partner to determine what action items are needed, for including legal intervention. We still have a no wrong door philosophy, but now we have a workflow for it, so it's more strategic. So patients who are screened by the community health workers, if they're in the target population, the community health workers will look in the electronic health record and see if their A1C is 9 or above, and if that's the case, then we refer them to our legal partner if they have a legal need. If a patient screens positive for needing legal services through the Prepare, and they're not part of the target population, then we still work very closely with our legal team to make sure that the proper referral is facilitated and the linkage actually happens through the community health worker. Next slide, please. In terms of integration, we had to think about how we're going to really solidify our team. And so we have team meetings every other week, and a representative from the legal team attends the meeting with our community health team. We identified a legal champion within the community health workers, and she's on the left there. And so she takes the lead on looking at our registry of all of our patients that we have with uncontrolled diabetes. She reaches out to them through a phone call to do the Prepare with them, and then refers closely with our legal partner. We look at patient encounters, so the attorney and the community health worker at times might meet with the patient together. So what we were having before is the legal partner was having trouble with the patients actually maybe responding to them. And the community health workers have such a close relationship with the patients that we thought that was a better way to sometimes facilitate that contact when the attorney is having trouble accessing the patient. And then our legal partner is fantastic because we all know on the team that we can pick up the phone and she's available, or they're all available anytime, and they really go above and beyond to help us. Our legal interventions benefit, the health center and patients. The legal team, they do individual cases, they address systemic legal interventions such as transportation. They're taking on Medicaid transportation issues here in St. Louis. They're working on housing. I'd like to share that my very first interaction with the legal team involved a patient who, because the community health workers came on board in January 2017. The first referral that was a legal issues for our team came in right that very first month, and it was for a patient who was, his lease was being terminated. He lived in a high-rise apartment in St. Louis, and his lease was being terminated after 8 years of living there due to certain behavior that they said that he was having. When we looked into it more, we could quickly detect that there was a legal issue. And what we found out was that the patient was in a power wheelchair, and he had not been able to access his bathroom for 8 years. His wheelchair would not fit into the bathroom door. So the legal team, addressed access issues within a high-rise, and didn't just benefit our patient who was faced with homelessness because he had a very short time where his lease was going to be terminated, but the legal team was also able to help address, fair housing for the whole entire high-rise, which benefited a lot of people that live there. We have legal clinics. We have in-services at our team meeting. The most recent one was an attorney presented about tenants' rights, which is what our community health workers and community health nurses deal with a lot, about patients facing unfair housing practices. We receive brief legal advice constantly in our team meetings. Our attorneys are fantastic. And other interventions, that we're planning and that we're working on is developing a Know Your Rights guide for individuals with diabetes to address that target population, and just partnerships with other community organizations like St. Louis Food Bank and other things, so that way we can really address the holistic needs of our patients. The medical interventions that we have also to address, diabetes, or that we are on the medical side, is that we have individual and group diabetes education through lots of different disciplines, and then we really work closely as a medical team to develop care plans that are coordinated through integrated multidisciplinary care teams. Next slide, please. So in terms of some of the challenges, though, I guess, before I get to data collection, are that we shifted this target population, and that was a process for our health center. So we had the original model, then we shifted. Some of the providers and healthcare team members were concerned about my patient being left out of the legal interventions, but the way that it's worked is, we assured them the community health workers would work closely with them with navigation of referrals if our medical legal partnership could not serve them. And it took time for us to develop new workflows with this target population. It takes time to devote staff time to systematically screen patients. Took us a while to develop metrics for data collection. And our legal partners currently do not have access to our electronic health records, so it requires a lot of verbal communication about where the patient's at, and it just takes a process. So here we are with data collection, and we have a practice analyst at the health center who helps us to develop our system for collecting metrics or deciding what metrics we wanted to look at. We ultimately right now are looking at A1C, blood pressure, BMI, and a PHQ-9 depression screening. But we're not set on those, so we're constantly exploring health data and qualitative measures that we can use to evaluate impact. Our legal team uses the Cohen Perceived Stress Scale and a legal outcome measure survey. We review status of legal cases on a monthly basis with our teams, and then we're constantly evaluating trends that are happening with that population to spread interventions. Next slide, please. Some challenges. I already talked about that. Sorry, my slides were out of order. Next slide, please. And opportunities that I think are important. That we have an opportunity to advocate for healthier communities in the St. Louis area through systemic legal intervention. One of the strategies that we used with our registry of patients with uncontrolled diabetes is we didn't just, we're not just going down the list in alphabetical order, but what we did was we looked at it with our practice analysts and looked at it by zip code and by race, because St. Louis has, pockets of the city and the county where there are no health centers within miles. There's no access to grocery stores within miles. And so we want to take that into consideration when we're screening our patients and what their needs might be, there could be definitely systemic issues. We're still evaluating that, but looking at the systemic issues within certain zip codes is one strategy that we're taking at this time. The other opportunities that we play a role in helping the health center meet the clinical quality measures that HRSA wants us to meet and that are best for our patients. We ultimately want to reduce the impact of social determinants of health and enhance the patient's experiences with the health center by, addressing their legal issues. Next slide, please. And my contact information, along with our legal partner, Amanda Schneider, who's the project director, our contact information is there, and feel free to reach out at any time. And I'll turn it over to Dr. Johnson.
Oh, okay, so I had to figure out how to get myself off of mute. Well, good afternoon. I'm the last of the speakers, so I guess they say the best for last, or just just put me in this sort of in this tier system where I can sort of bring up the rear. I'm a general pediatrician in the School of Medicine at Emory University, and I'm also director of a program called Partners for Equity in Child and Adolescent Health. And the purpose of Partners is to increase access to healthcare and also to improve the delivery of healthcare for at-risk and underserved children throughout the state of Georgia. And our vision, which is a bit lofty, is to reduce health disparities so that the children of Georgia are more likely to grow up to be happy, healthy, and productive members of society. Next slide. So the goals of Partners are fourfold. I'm involved in school-based health centers. I have been involved for the past 22 years, and for the first 15 of those years, we only had 2 school-based health centers in the entire state of Georgia. And when I left managing those 2 school-based health centers, I had a goal of expanding the school-based health centers by 2 to 4 each year. And as a result of the efforts that I'm not going to talk about today, we've increased the number over the past 5 years from 2 to 38 school-based health centers throughout the state. The second goal of Partners is to improve the delivery of healthcare for at-risk children and adolescents through a family-centered approach. And this is the work that we're doing in the primary care clinic at our local children's hospital that's affiliated with Emory University. And the third is to improve academic outcomes for underserved children, beginning when they're born and emphasizing early childhood literacy and monitoring children before they fall behind in their academic progress. And the fourth thing we do is our goal was to change the culture of how we train residents so they can understand the value of addressing social determinants irrespective of what discipline of medicine they chose to go into, whether they went into primary care or subspecialty. We wanted them to understand and embrace social determinants so that they could apply it no matter where they went. Next slide. So I'm going to talk we're going to talk about our second goal, which is to improve the delivery of healthcare for at-risk children and adolescents through a family-centered approach. Approximately about 7 years ago, we developed and began implementing a family resource survey in order to identify which, if any, of the social determinants of health were impacting the outcomes of our patients. So in our survey, we assessed the housing, as with all of these surveys, food insecurity, housing insecurity. We also look at domestic violence, depression, school failure, and substance abuse, among other things. And we administer these surveys when the families come in for the very first visit, and then we continue that every year thereafter. Once we complete the survey, we scan it, it's a paper document, into our EHR so that we can have it as a reference. When we developed the survey, we realized if you're going to ask a question, you better have resources to address whatever question that you asked. And so we developed a resource and support system that helped us in addressing the social determinants. We hired a behavioral health coordinator as part of that support network. And we also began a case management program, which really mirrors a lot of the programs that you've already heard about today. We targeted families who had very complex medical issues, but also those who had very serious and significant psychosocial issues that really impacted a child's ability to do well. And we began the process of identifying these families, not only through the Family Resource Survey, but also through more in-depth interviews when they would come in for our primary care clinic. Next slide. We named this case management program PACE, and it stands for Pediatric Primary Care, Access to Health Care, Comprehensive Family Support, and Educational Achievement. It is a multidisciplinary, interdisciplinary approach to addressing both the social, emotional, physical, and legal health needs of our at-risk patients and their families, and is staffed by medical providers, our lawyers from the Health Law Partnership, nurse navigators who are part of the hospital system, social workers who are also part of the hospital system, and the behavioral health provider who is really hired through Partners for Equity in Child and Adolescent Health. You can go to the next slide. We just want to say that, when we got started, we were able to do this work because we were funded for 3 years to hire not only the behavioral health coordinator, but also we were able to support about a third of the salary of a lawyer from the Health Law Partnership. And it was really the first time in the history of our organization that we were able to integrate and coordinate the work of not only the hospital's medical team, but also the legal team, the social workers, the navigators who in and of themselves are wonderful wonderful social workers and resources for families, and the behavioral health coordinator. The Health Law Partnership had been in existence for several years, and we, even though they were stationed in the clinic, we rarely talked to one another. If we had a legal problem or suspected there was a legal problem, we would refer our patients to the Health Law Partnership lawyer, and she in turn would try to get an intake at the time that the patient was in the clinic. But more often we would give our families brochures and say, please call this number if you want to speak to a lawyer to address some of your issues. What we found is that our families never really called the lawyer. Sometimes when they were there and they could get the information directly, the lawyers would follow up once they got consent. But the majority of our referrals were through brochures and word of mouth, which really wasn't working well for anyone. Not only that, we had no idea what was happening to these families once they were referred to our legal team. All right, I kind of lost my computer's gone dead on me. Hold on for a second. Okay, I think it's coming to life.
And while we wait for Dr. Johnson's computer to come up, if you have any questions for Dr. Johnson, please send them in the chat box. Is your computer back, Dr. Johnson?
It's back. I don't know what it's doing. Great. I'm doing this all day. I'm sorry. I apologize. So
no problem. Thank you.
It's okay. We really need to create a system where we could, first of all, talk to one another and find out what was happening with the patients that we were referring. And also, how can we work together to learn from one another so that we could integrate our work so we could do our work better. And so the PACE program gave us an opportunity to do that. And so how do we work together? We have really evolved over the years from just, just superficially discussing patients and getting advice and asking questions as we pass through the hall, to meeting once a month in a forum that allows us to not only talk about our patients, but also to share information and data and to learn from one another and teach one another. And we've come up with systems where we get consents from our families so that they know that we are talking about their legal issues and that the legal providers are also learning about their medical issues. And so it really is a truly an integrated, collaborative approach that allows us to not only talk about issues, but also learn from one another. As a pediatrician, I had no idea that there was a difference between guardianship and custody. I thought it was one and the same. I had no idea about the issues around fathers having legal custody of their children if they're not married to their mothers. I had no idea about the steps you need to go through in order to not be evicted. I was always told as we were growing up that if the landlord didn't do what they were supposed to do, then you need to stop paying them. And our lawyer said, no, you don't do that. You pay your rent until such time that you can get before a judge and plead your case. And so we've learned so many things that not only have we been able to share with one another, but we can take it back to our patients and share that information even though they don't require having been paced, as we call it. Next slide, please. So the structure of our PACE is this. We identify our cases, and it can come from anywhere. It can come from the medical providers, it can come from the social workers, or behavioral health coordinator who actually is our administrator for our PACE program, or our lawyers. And we do our family resource survey, we do in-depth discussions with our families, we monitor them over the course of a time and realize that their conditions are much more complex than we ever thought. And then we realize that these patients would benefit from being PACed. Once they're referred into our system, we create very specific benchmarks for them. And it can fall under the heading of a medical issue that we want to follow, a legal issue, a behavioral health or educational issue, or a combination of all of them. And oftentimes, it's usually 2 or more issues that we're following over the course of serving these families. We meet monthly, where we not only exchange information, but we coordinate our care. And sometimes when we come together, we realize that the efforts that we're making alone clearly do not create the outcome that we want without getting input from one another. We problem solve all the time. We monitor progress, and it's a slow process. We laugh and say it's sort of like watching a soap opera. You can watch one episode and then you can wait and pick up the episode 3 months later, and everybody's doing the same thing. But sometimes that's the case with a lot of our families. It takes a lot of effort, a lot of intervention, a repeated intervention from all sources. Sometimes when we can't quite get what we want with one particular entity, we will refer them on to the other to see if they can work with our families. But it takes a long time, but it is a very constructive, effective means by which we address the complex issues of our family. Next slide. Some of our outcomes to date, we've been evaluating from 2011 to 2016. We've had about 121 cases referred into PACE. And as you can see, the majority of them deal with counseling and behavioral health services and psychosocial services and social support. Even though we have a large number of families or children with medically complex issues, the primary issue for them is not their medical diagnosis, it is all of the behavioral health issues and the lack of social supports that they have. So we spend an inordinate amount of time addressing not only medical management and making sure these children get to their appointments and that they are progressing medically, but also that the issues and the dysfunctions and the challenges within their homes are addressed as well. And so we spend most of our time doing that. All of us do. The lawyers spend a lot of their time also dealing with behavioral health issues as well as legal issues. Clearly, the medical group deals with them as well. And so it's a wonderful sort of infrastructure that allows us to do all of these things together and to do it better. We've seen a lot of our patients who initially refused to go for behavioral health counseling support, eventually, after being approached by the nurse navigator and by the social worker and by the medical provider, realize that this is an important entity for them, and they end up going. It may take them a while, but we've seen our patients becoming more receptive to the need to go and receive behavioral health and mental health services for themselves. We're talking about the parents as well as the children. And so we've been probably more successful with this arrangement with parents than we have alone. We've seen a lot of our children receive IEPs and 504 plans. The school system, it takes them forever. And it's not because they don't care, it's because they have so few resources. We have so few psychologists here in the metro Atlanta area, and we have so few people within the school system who are organizing and managing these children with learning disabilities and behavioral problems that it takes them forever. And if you don't have someone who stays behind them, then oftentimes they'll let it slide until they can get to it. Oftentimes we will have our lawyer just write a letter And so we realized that, the family has been going through this process for several months. We realized that, you have challenges, but you really need to make every effort to address or to schedule an IEP or a 504 meeting for these children. And every time we get a letter from the lawyer, it just expedites everything. So we really appreciate their help with that. As they stated before, housing issues, mold, substandard housing, things that don't work within the home that families have to try to deal with for years and years and years. It usually takes a legal approach in order to get the landlord to agree to address these needs. And they also, as I said, provide invaluable information on how they should approach it and how they should work toward doing it in a way that they won't get evicted. We've had, as I said, a lot of our families who have had problems getting access to SNAP program and other state support. The lawyers just step in, make a phone call, and it's amazing how these entities respond to them. We've had patients with very complex medical problems who are just not compliant because they're living from pillar to post, and because they don't have transportation, and because they have other priorities in their lives, like having a roof over their head and food in their cupboards, that they don't address. They're not compliant with the medical needs of a medically complex child. And so our nurse navigators, along with our social workers, along with our lawyers, when it comes to issues around transportation and we have some really unusual transportation issues here in Georgia, where the Medicaid transport puts a lot of restrictions on who can come to a visit. And if a mother has 3 or 4 children, sometimes they will say only 2 children or 1 or 2 children can come. But when we have our lawyers to contact them and to plead their case, then it really expedites that as well. They have also worked very closely with our medically complex families who qualify for SSI. They're not involved with the initial application, but if they are denied, they are right there to assist the families and to help them navigate the system and reapply so they can get the SSI for those children who really need it. As I once said before, guardianship and custody is just amazing. I had no idea the difference in what and the impact that it has on these families who are taking care of these children, but they have legally not gained guardianship or custody. Their inability to get Medicaid, their inability to get financial support for these children is just amazing. And our lawyers have really worked hard to educate us, but also to assist these families in getting the guardianship and the custody and dealing with the custody challenges that they have. And finally, there are times when with our best effort, we really can't get our families in a position where they can effectively take care of their children. And we think children are suffering, then sometimes we have to advocate for them to be taken out of the home and placed in a more nurturing and supported household. And we don't do that very often, but sometimes after months and months and months of managing these cases and trying to help these families in every way that we can, we realize that they can't overcome the challenges in their lives. And in order not to allow this to impact this child in an ongoing negative way, we advocate to have these children taken out of the homes and placed into these nurturing and supportive households until such time that their families can be in a position to take care of them. So we've had some tremendous outcomes. These are a few. We have wonderful stories, which we don't have time to go into now. But the PACE program is probably the best aspect of the work that we do in our primary care clinic, in our local children's hospital. Without the lawyers and without the other members of our PACE group, the nurse navigators who are just extraordinary. I mean, the things that they do, they go into the community, they hold the hands of these families, they expedite things that in ways that we never imagined that they could. With our social workers and with our behavioral health providers, along with our medical providers, working together, we have really been able to turn the lives of a lot of these families around and to help these children who otherwise, by ourselves, would never be able to help. And so this is a model that I think needs to be replicated everywhere. There's so many things that we just don't understand. And definitely there are a lot of things that we just can't do on our own. And I really appreciate the opportunity of the past 6 to 7 years of being able to work with our partners to achieve these outcomes for our children. My next slide, I think it's just my contact information. And so if you're interested in more of what we're doing, please don't hesitate to reach out to us, and be happy to share with you whatever I can in order for you to be able to do this work as well. Thank you.
Thank you. And I would just like to thank all of our panelists before we go ahead and get into the question and answer portion. Next slide. We appreciate all the questions that have come in, and I'm going to go ahead and kick it over to my colleague, Ellen, to go through some of the questions and have a discussion with our panelists today. Ellen.
Great, thanks, Sharina, and thanks to our panelists. And I'm going to try to pull together a couple of themes here, and then we have some questions that we want to pose to some of you individually and some of you as a group. And, you know, as a team, Sharina and I and our colleagues working with health centers and PCAs around the country and helping to bridge with the legal community and think about how to integrate legal services into the work that you're doing in your health centers. You're each invaluable resources, each of the panelists presenting, I think, really unique, but also in some ways foundational perspectives about how MLP operates. I love Dr. Johnson's story about, you know, having worked down this call from the lawyers, but not really integrated and communicating and thus not being as effective. I also appreciated hearing from Jill about the pivot that they did to narrow and tailor the work and the referrals, knowing that they might reach a smaller group of patients, but that they would be able to deliver a different kind and quality of work. And then from Martha, really inspirational about the potential for thoughtful individual advocacy to bridge into something much bigger than all of us that could really impact many, many more kids. And so those perspectives, I think, are really important. And you can tell that hearing from each of the speakers, these are relationships that take time to develop. So that would be part of what I would share with the audience, is that if this is something that you're working on, that you're in the middle of, or you're just getting started, this does take time. It takes time to build the relationships. It takes time to think about how to deploy your program, and it takes time to think about how to have the impact that you want to have jointly together with your legal partners. So I just think about that, and I would really reflect too on some of the numbers that we see are relatively low in terms of the individual patient interactions that you can have. But you heard from each speaker about the ripple effects that are happening across patients when Dr. Johnson knows the difference between custody and guardianship and is better equipped to do some of that work because of the training that she's received, and the same obviously for Martha and all of the great work that she's done, and the recognition by Jill that, you know, the team, the community health worker team that's meeting, really does need to have a lawyer as part of the team to tackle some of these really complex problems. So those are just a couple of the themes of the work that's being done out there. So there are a couple of questions, and so I'm going to call on people so that you don't have to raise your hand. But I'd like each of you to think about if you had 10 minutes with your CEO and wanted to communicate the value of this work, how would you do it? That was one question that came to us over the chat box. How would you communicate the value of this work to your CEO? Okay. And then tell us also, you know, give us a ballpark of what does the program cost, if you know, because I'm sure there are folks out there that are thinking it. We've got a couple of questions across the chat box. I want to do this. You don't have to convince me. How much does it cost, and where does the money come from? So some of you may not be as closely tied to those roles, and some of you may be. And so I'll offer that to each panelist. So Martha, if I can kick it to you because you're the longest practicing MLP person, what would you say to your CEO if you had the chance? And tell us a little bit about, you know, how this is funded and Go ahead.
Hi. Yeah. I think I would just look at the kinds of things that affect our patients' health that we can't fix as providers. So when you have somebody who has asthma and they're living in a moldy environment, we can't fix it for them. So this is just really something that can really impact our patients' health outcomes. And, you know, I think when we looked at the finance piece, we kind of went into this really without having to, we went in as a partner. Like when Loyola approached us, we didn't have to fund the salary. It was completely funded by Loyola. And we were also fortunate to find some grant money available. So, you know, once that ran out, we did need to like think about, once we could see the value of it as well, then we did actually contribute to the salary of one of the legal partners that works with us. So, you know, it's sometimes you have to try different things, you know, and until you really start to see how it impacts your patients, you won't really be able to assess whether this is something you want to continue.
Got it. Great. Thanks. Jill, do you want to offer?
Yes, hello. I would say two things to our CEO. I would say one is that attorneys have the opportunity to address systemic issues and affect policy changes in a little bit different way than other advocacy avenues. You know, there's a difference between addressing individual issue after individual issue and affecting policy that can help all of those individual issues that arise with our patients, whether it's lead or, you know, asthma or, you know, a lot of different health, you know, health conditions that we are all trying to improve on a population health management model. And the second thing I would say to our CEO would be that it could take a lawyer 5 minutes to do something that it could take a social worker or a community health worker or a patient hours upon hours upon hours of trying to resolve, which ultimately is to the detriment of our patients and a lot of stress that they, you know, go through. I give this example a lot of times about a patient, because this has happened, the patient who, you know, needs their kitchen sink fixed, and the patient calls the landlord 5 times, and then the social worker calls, or the community health worker calls, the landlord's still not listening, and then the attorney writes a letter, and then the sink is just fixed. And so that, it can take so much time and stress for our patients, and, you know, an attorney sometimes can affect change in a way that others can't. So those are the things that I would say to our CEO. And I do know that our medical legal partnership is grant funded, and it's shared with 2 other partners, the Integrated Health Network and Affinia Healthcare in St. Louis. I don't have exact dollar amounts in terms of what all goes into it, but I know that we're currently, you know, trying to plan for an extension of the grant or, you know, new funding opportunities.
Great, thanks, Jill. Dr. Johnson?
So this has been a big issue for us because we're part of a very large children's hospital whose primary focus is in inpatient and subspecialty care, and we run a very robust primary care center residency training, medical school training program within the children's hospital, and they really don't understand why we need to do all of this work. It's really about numbers for them, and getting patients in, getting them out, and the bottom line and all of that. And so we've really struggled with this when we go to them to say, you know, we really need these services because of the clientele that we serve. Only until the hospital system decided to go after a patient-centered medical home credentialing, that they realized that we needed all of these services to work in tandem with one another in order to create a system that really allowed them to achieve this patient-centered medical home. And when they did, I mean, it just completely changed the whole perspective of all of the folks in leadership, because they realized you have to have all of these supports in place for families, and having the legal piece was just icing on the cake. And so we don't have to say anything to them anymore, because they all of a sudden, because of their desire to receive that patient-centered medical home qualification led them in that direction. In our program, our funding really, the funding that we had to be responsible for was really for the lawyers and for the behavioral health coordinator, which cost us about $135,000 a year, which came through grants. But even after the grants were over, we've been able to sustain that. And I tell you, the beauty of partnerships is that you have multiple funding streams based on who your partners are. So you're not responsible for everyone's salary, for all the expenses, because you have different entities that are working together, integrating their work, that have separate streams of funding that contribute to your program as a whole. Our nurse navigator is hired by the hospital and paid by them. The social worker is hired by the hospital and supported by the hospital. The behavioral health coordinator is supported by our program at Partners. The lawyer is basically supported. They're part of Georgia State law practice and legal aid. And so they, supply the funds for them. And so we work, so right now the cost is minimal to us only for the behavioral health coordinator because everyone else has their stream of funding. And I think that is the only way that you can actually make this work and sustain it, is that you create these true partnerships that have different sources of funding so that they can contribute their staff person to this process.
Great, thanks for that. Okay, we're going to go from big picture vision right down to the nitty gritty, which is that inquiring minds in the chat box want to know, how do you get permission to share this information? I think we heard Jill say that the legal aid is not sharing information with the EHR. And I think, Dr. Johnson, you talked a little bit about some of the consultation or information sharing. So we don't have to go into a deep review of HIPAA, heaven help us. But I will say that the National Center, because we get a lot of these questions, how can we share information with each other and do it in a way that's, safe and appropriate and professional? We generated an issue brief, and Sharina's not busy. She can pop it in the chat box, that focuses on privacy and information sharing. And so this is an issue that folks worry about. And we've tried to gather best practices and share them with the field, but know that there isn't one single strategy that everybody uses. It's a little bit all over the map around the country, but very important. How are you sharing information? What information are you sharing? And so if we can take it from the top, again, Martha, Jill, and then Dr. Johnson, that would be great. Just to hear a little bit about that information sharing, what's happening, and what would you like to see happen? What would improve your ability to take care of your patients and problem solve if you had those? Oh, I'm just remembering that Martha had to step out. Okay, Jill, do you want to come in and talk about that? Because I know you flagged that as an issue.
Sure.
Information sharing.
Yeah, in terms of information sharing, for us, we do have permission to share on a need-to-know basis information that the attorneys need to be able to, serve the patient. And then also on the back end, when we're looking at health data to match it up to legal interventions, we have the ability to share that. We do that, through spreadsheets and encrypted emails and all of those things. We have the go-ahead for that. The one roadblock at this time is just, the attorney being in the electronic health record and possibly, writing notes in the electronic health record for the medical team to see. And, the way I view that is just that it's a process, just like everything else has been a process up to this point. But because of HIPAA and, everything, all the, considerations surrounding that, that's just been a longer process, I would say, for us to get our attorneys access into the electronic health record. But, verbally and in meetings, and we have, patients sign, authorizations that way we can share information with one another, and we do have that go ahead to do that.
Yeah.
Great. Dr. Johnson?
So I agree. It's all about consent, right? And so not only do the lawyers get consent to share the information, the legal information, we get consent to share the information, the medical information. And we have the same problem. The lawyers can't access our electronic health record. However, we have created a form that when we refer to our lawyers and they have some report, they fill out the form and send it to us, and then we scan it into the medical record so that we can view it and get the information that way. Another thing that we've been able to do is when we refer, so one of the issues, like I said before, is that we would, when we would refer a patient to Health Law, we would just give them a brochure or give them the number and say call, and of course they never did. So what we were able to do through our EHR, the Health Law Partnership is one of our referral sources. We refer through our EHR. We get permission from the family to allow the lawyer to call them, which is something that has really worked well for us. And then we also get the number, because we found another thing I didn't understand is that as a lawyer, you just can't talk to anyone in the home. And you've already opened a case with another family member. You can't open another case with with a different family member. Didn't know that either. And so we ask those questions before we refer them. We get permission to allow the lawyer to call them. We get a working number so the lawyer can call them, which has really improved communication tremendously. And then we review all of these cases during our monthly meeting. One of the other things we do during our monthly meeting, even if we're not pacing a particular family because they're not that complex or their issues are pretty simple, we still want to know what happened to these families. And so our lawyer will read out what's happening to them, where the case is, whether or not they could contact the families, whether they refer them on to someone else. It's just amazing how we're able to share information through that monthly meeting, but also through the form that the lawyer fills out, and also our capacity to refer in a very effective way.
Great, thank you. Okay, so we had a question come in about screening, and so that gives us an opportunity to share a our screening resource, which is an issue brief that looked at screening practices across 13 medical legal partnerships. And, you know, either Jill, I think you shared a little bit about your screening process and that it's a work in progress, and Dr. Johnson, you've also shared about that, but if you had any other thoughts about, you know, who's the best person to do the screening, for example, in terms of health-harming legal needs.
Sure, this is Jill. You know, we have, you know, with the implementation of community health workers who oftentimes access patients' information in a different way because of the definition of a community health worker being part of the community, a trusted member of the community. A lot of times patients will tell community health worker things that they haven't told other care team members. And so, you know, we believe that that's an effective approach to, you know, screening with the prepared tool and, you know, adding on some more questions that are pointed towards legal needs. And, you know, we've had some, you know, success with our patients, you know, letting the community health worker know what was happening. And then, you know, often that will lead into, you know, a phone call or in a meeting talking with our legal partner about, you know, does this really fit? Because that's the other thing, too, is that the community health workers are still learning about, you know, what is the best, you know, what could be best served by the legal team. You know, is this a legal need or is this something that they could do? So having that ongoing communication with them has been, with the legal partners, have been so helpful because it also helps guide the community health workers in terms of their intervention.
Yeah,
great. And oh, go ahead.
No, I was just gonna echo this. I mean, screening is multidimensional, right? You have a screening tool that sort of guides you in how you approach families. But I agree, you know, once our behavioral health person or a navigator starts talking to these families, they open up and share things that you could never get out of just one screening instrument. And so it's an ongoing process, multidimensional, and it really speaks to the relationship that these, and I have a very strong relationship with my patients, but with the behavioral health and with the navigators, the relationship they develop with these families over time, how they open up and really reveal to them and the group as a whole what their needs are. So it's great to have a screening instrument. We actually use it for our residents because we're trying to train them around what you should ask when you go in and see a family, and get away from just the pathophysiology of disease and really start looking at all of the social determinants. And so we created our screening tool to help them, because those of us who've been doing this work for 20, 30 years, we know what to ask, and we can ascertain when families are really struggling. But it is multidimensional, and I think that's something really important to understand.
Great, thank you for that.
I add one more thing in terms of Dr. Johnson sparked my memory in terms of the multi-dimensional approach to screening, and that is, some of our assessments are done in the community, and sometimes our patients don't think to tell us, like, hey, my landlord is doing this, or won't turn my power on, or, different things with housing. And when the community health workers go to their homes, they often are, cued into, hey, that's a legal issue that can be addressed by our legal partners. So some of our assessments are also done in the community, which opens up the eyes and ears of the health center and our legal partners too.
Great, thanks. So we've had a couple more questions come in, so I'm going to try and tick them off. One question, and Jill, I think I know the answer to this, which is that the diabetes, it asked if the diabetes-focused program has any outcome data yet, and I would say it's pretty minimal at this point, right? You guys are just getting going. So
yes, you're right, exactly.
Yep. And we got a question about what's the most common legal issue, if there is one. And I think that I can tell you from a national perspective, and this is a great thing to look at our 2016 site survey to get this data. Pretty much at the top of the heap is housing, and that's probably not a surprise to anybody. And then public benefits, and that ranges everything from health insurance to SNAP benefits to Social Security and disability. And then the third most common legal issue is around family law issues, and that is a pretty big bucket and covers a lot of different territories. But I think every program, tends to have at least housing, but it also can dovetail with what is the capacity of your legal partner and what is their expertise. And so that's part of the planning process, is devising, what can we do as partners together, and what do we have the expertise to do? I have another question for Jill and Dr. Johnson. In terms of following up on a positive screen, when you've provided assistance, here's the question: what, if anything, do you do to see if your intervention assisted the patient? And I know both of you have kind of responded in different ways to that question. And then the follow-up on that is that tracked in the EMR? What does that look like? So I know you've kind of tackled different parts of that question, but I wanted to bring it back around again.
Sure, this is Jill. We're looking at health data, with our target population. So we're looking on that end to see if outcomes are any different. We're also, it's a couple of different things are happening at the same time, as our community health workers are providing interventions and our legal team is providing interventions. So we're looking at all of that. We had a focus group. We're looking at different ways to collect qualitative data to match that up with the health data. And then our legal partners, they also have separate scales that they use, the Cohen Perceived Stress Scale, and then their legal outcome scale. So we're just putting all that together. That's not, other than the health data, we're not documenting the qualitative and the legal surveys. We're not putting that into the EHR. But we do evaluate it on an ongoing basis with our chief medical officer, with our legal team, our practice analysts. So we have a team here that is constantly monitoring, what data are we collecting? Are we collecting the right data? Do we need to shift on, what data we're looking at? So we're constantly reviewing that since it is still so new.
Great. Thank you, Jill. And okay, we're going to wrap up in a minute, so go ahead.
Okay, so we actually track our data through our monthly case management. We establish metrics and benchmarks when we refer them into the PACE program, and we actually monitor the progress of that and decide whether or not we're going to dismiss them from the PACE case management if they've achieved whatever the benchmarks they have. And we've seen a lot of positive results around the outcomes for a lot of these children. I have a wonderful case where a mother was really stressed out, and she had children who had very severe medically complex issues, and she was wasn't a very good caregiver at all, and one of her children was failing to thrive just significantly because she just couldn't invest in the life of this child. And when we got her help, the child started growing, and it was no longer a failure to thrive. And you can see exactly on his growth chart when the mother got help. And so we do monitor a lot of that. We also follow a lot of the behavioral health referrals to see, if they actually made it to their visit and what were the diagnoses and how well these children are doing as a result of their therapy. And it's all integrated into the medical care. And so as we see these children over and over again, back and forth in the clinic, we can gauge how well they're doing based on the interventions that have been done, and we track that in the medical record.
Great, thank you. And I've gotten the signal that our time is up here, and we have a couple of wrap-up things that we need to do before we let you go. And just really want to thank our panelists and thank our friends at School-Based Health Association. And I'm going to turn it over to Sharina to take us out. Sharina?
Thanks, Ellen, and thanks again to our panel. So we just have a couple more things to tell you and give you some updates. We will be doing a learning collaborative in the 2018-2019 year. So these learning collaboratives will focus on a variety of different topics, and we really value the feedback that you all have offered us so far on which topics we should focus on. You can go ahead to the next slide, Kaylin. We have released a very, very brief survey in the last week about the different topics that we hope to focus on in our SDOH Academy Learning Collaborative. If you haven't had a chance to respond, I just stuck that in the chat box. If you could just take some time to complete this very, very brief survey, it will only take about 4 to 5 minutes. We really appreciate your feedback. Next slide. And you're going to be directed to another brief survey about this particular session following the end of the session. You'll be directly redirected there, and we really appreciate any feedback about this specific session. Our next virtual training will take place on Thursday, March 10th, and it will feature panelists from the following national cooperative agreements: Harvard Equitable Care for the Elders, National LGBT Health Education Center, Migrant Clinicians Network, and the National Center for Health in Public Housing. So those are our final announcements. If you have any further additional questions for our panelists, please feel free to offline with them. Again, their contact information was available in the PDF, and you'll be getting that as a follow-up. And you can also direct any questions to me, and I can get those to the panelists as well. So again, one last thank you to everybody for joining us today and for our panel, and we hope you enjoyed the session. Thank you so much for your participation. Bye.